I'm Stephan Achenbach, and we're going to talk about pericardial diseases because a new guideline on pericardial disease has been issued at the ESC Congress in London 2015, and this is where we currently are. With me are Philippe Charron and Yehuda Adler, the two authors of this guideline, and Stefan Agewall, one of the review coordinators. So Stefan, tell me, what struck you as the most important new aspects that are found in this guideline?
Stefan, if we compare with the 2004 guideline, I would say that the colchicine has become a standard treatment and has been upgraded to a 1A recommendation. And into the new guidelines, the authors have given quite specified instruction about exercise restriction. And they have proposed a new triage about to handle acute pericarditis, and the use of MRI has been upgraded, especially when troponin is elevated.
Yeah, I think we should talk about these aspects. And Yehuda, can you tell us about the medical treatment of acute pericarditis, the new aspects?
Yeah, I think if we'll, like Stephan said, if we'll compare the new guidelines to the guidelines we published in 2004, were the first guidelines for pericardial disease ever, the colchicine, we have an old drug for an old disease, but a new treatment. And it's very rare, in medicine, not only in cardiology, in medicine at all, to find a new drug. And the drug was in our hand. Colchicine is a drug, it's an anti-inflammatory drug. We treat this drug, for instance, for FMF, familial methylmalonic fever, for gout. And nobody knew that colchicine can help people with recurrent pericarditis.
So what are the specific recommendations now? Do you use it all alone, or how do you use it?
So for the first time, we have prospective studies on a lot of patients, double-blind, who prove that colchicine is a treatment for acute and recurrent pericarditis to be given with aspirin or non-steroidal anti-inflammatory drug, 1A.
I think it's very important to give it in combination.
In combination, because we treat the acute and we prevent the recurrences. And this is a new treatment for this disease, and I think it's a great achievement for this field. Another point which is very important, the corticosteroids. Usually, all over the world, people were treated with corticosteroids because people thought corticosteroids give a relief and prevent the attack and so on. And we proved in a prospective study that corticosteroids cause the recurrences. They increase the incidence of recurrences, so we should avoid corticosteroids, and corticosteroids not longer as first line of treatment.
Yeah, that's certainly
only aspirin, non-steroidal, and colchicine.
That's certainly a very, very important message. And in fact, you have to think about the entire algorithm of approaching these patients, and they're nicely outlined in the guideline. Can you tell us a little bit about the treatment or management algorithm?
Yes, this is, I think, an innovation that is very important for practice. When we see a patient with acute pericarditis, we propose an algorithm for the management of these patients in order to know, after a triage of these patients, to know if we need hospital admission or not, and if we need to further investigate the diagnostic workup and to search for etiologies or not. So these are two important questions for such patients. So we used risk factors that should be searched for, and in the presence of these risk factors, it is important to propose hospital admission and to continue the diagnostic workup. These factors were assessed by multivariate analysis for some, or with univariate analysis for some. So I think this will help the clinician to better manage the patients at the entry phase. So when the patients need to have further investigations for the diagnostic workup, the rationale, of course, is to search for etiologies that need targeted therapies, especially bacterial etiologies or neoplastic etiologies or autoimmune disease. And we proposed, and this is an innovation too, first-line investigations to be performed in all patients with acute pericarditis. And we propose second-line investigations,
in selected patients,
including multimodality imaging with MRI or CT that may provide additional findings. So this may help help in practice, I think, the clinicians.
Very good. Thank you very much. So we have very new important aspects regarding both treatment and management in these guidelines. And I thank you all for helping us discuss these. Thank you very much for your attention.
Thank you.
Thank you.